Good morning.
How are you?
Look, I'm fine. Look, old habits die hard. How about I have my thing ready for Clubhouse, and I'm like, oh, we're not on Clubhouse.
Wait a minute. How about I feel like I need to be doing something? Like, wait a minute. During the intermission, I'm normally fixing and running and doing all of the clubhouse things, and there was no clubhouse things to do. And I feel like I don't have enough light. I should have brought my ring light. That's what I should have packed. How about I'm gonna start packing? I always pack my tripod. How about I'm about to start always packing a ring light too? And microphones. That's gonna be next. Gonna be on the always pack list. How was your week?
It was pretty good. Interesting. I have two quick backstories for you after we finish.
Oh yes,
They're,
sir. I
they're not
love
for the public.
backstories. Look, we need to be capturing the backstory. That could be a whole other conversation. That would be for the
Look,
Patreons. Look, that would be for the paid content.
yes.
Come to the
Look,
backstory. Let me
or
write that down.
as it's referred to in the workplace, the meeting after the meeting.
The meeting after the meeting. I love it. See, here we go. Uh, Let me write this down. If you want information for the meeting after the meeting, look, I'm about to do a whole commercial. Okay. Look, I'm so nervous because I'm on Central Time. And so I'm like, oh my God, I don't want to miss it. Let me make sure I'm right with the time and all of the things. It's crazy. It's crazy. Good morning. Good morning, Vicky. Welcome, welcome, welcome. Look, I don't have Clubhouse people to welcome, but good morning to everyone who is joining us. Well, I guess we can go ahead and get started, especially so we can get to the meeting after the meeting. I'm excited. Welcome to our Saturday morning tea, where we discuss health information, news, education, certification tips, entrepreneurship, nursing information, physician or provider information, physician associate. Look, you name it, we discuss it, especially if it revolves around the business of healthcare and revenue cycle. As you come in, don't forget to hit the thumbs up or the like button. Even as you go out, don't forget to hit the thumbs up or the like button. I am Clarice Warner. I'm the girl with the pearls, the founder and senior education director of the Professional Reimbursement Network, LLC, where coding education is key. PRN is a healthcare compliance consultancy located in Cincinnati, Ohio, that specializes in revenue cycle and regulatory compliance and education. And let me ask, do you know what it takes to be a certified marketable medical coder? Well, before I introduce my co-host, let me share with you some game. Let me put you up on game, as they would say, about the information on a free 99 email course on the 5 steps to become a certified marketable medical coder.
Are you interested in medical coding, but not sure where to start? And scared of wasting time and resources? Let me help you with the right steps to become a certified marketable medical coder. Learn more at bit.ly/5stepscoder.
Oh, see, you call me again. If you are interested in getting more information about the 5 steps to become a certified marketable medical coder, and you are joining us via YouTube, Facebook, and or LinkedIn, check out the video description for the link. I promise you there's a lot of information there, but the link is there. So joining me today is my co-host, Mr. Jesse, the registered trademark, put some respect on his name, the coding nurse. Sir, introduce yourself and tell the folks all about you.
Good morning, everybody. My name is Jesse. I am an LPN. I live in Philadelphia, Pennsylvania. Been in healthcare for a very long time. During the pandemic, I created a company called the Coding Nurse LLC, where I help other nurses and people with clinical backgrounds transition into the wonderful world of HIM.
And how's that going for you, sir?
It's going great.
Okay.
I enjoy it. I currently have a CDI trainee, and it's we're progressing because we're at the phase now we got to put it all together.
Okay.
So
Yeah,
yeah,
but
so
you
we're
you
doing
provide the introduction and all the little pieces, and then the magic happens. Let me show you how the magic begins. I
yeah,
love it. I love
yeah,
it. That's when they get the big eye.
exactly.
Like for real, it's about this and that and the third, and yeah, it's about all of these things.
Yeah, so we did our first sample chart this week, and it
Oh,
was
that's the fun
something.
part.
It was something.
That's when you have to come back in. Like it's okay. Don't be
Yeah,
nervous.
yeah,
Don't run away from it. It ain't gonna bite you. Because folks
exactly.
they get real nervous when they see that first actual. Well, wait a minute. This is what you do. It's not just this one liner or this one little word or this one look. No, ma'am, and no, sir.
You got to read the entire note.
Oh my God. Yes, 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 yes. Oh, well, you having fun over there. I'm jealous. I'm jealous. I love
Mhm.
it. Okay, so before we jump in today, let me remind you that you can join in and add to the conversation. Don't be shy. Your opinion matters and is always, always welcomed here. So, for my Facebook, YouTube, and LinkedIn friends, you know what to do. You use that chat. That's how we will engage in conversation regarding our topic today. And I would like to ask if you have a question, please type in Q first, just the letter Q, so we know that it is a question and we don't miss it. Because sometimes we get all wrapped up in the whole conversation because it's a whole conversation in the chat. We want to make sure that we get to your questions. So please do that. So let's get into it today. Let's get into it. Um, let's see, church announcements, church announcements. Um, let me see. Where's my church announcement banner? Where do I put it? Oh, it's over here. Okay. Church announcements, church announcements. Okay. So our church announcement for today. Have you heard? Let me ask this question, and Mr. Jesse, I know you probably already know, but for those of you who are watching us today or watching the replay, have you heard about the right of access and information blocking? Prayerfully you have. It's been a little bit of topic of discussion all over the place. And the right of access and information blocking are both about um, the access and sharing of health information. Good morning, the crafty coder. But anyway, the right of access and information blocking are both about the access and sharing of health information, but they are different in several important ways. And there are two different laws that govern how they work and how they are managed. Health information management and HIPAA privacy, security, and compliance officers need to know the difference to make sure that they are in compliance with these laws and with these rules. So, for church announcements, I want to let you know to be on the lookout for our video that explains the difference and it goes into detail about those laws and the differences between the two. So, be on the lookout for that. And that's my church announcement. Mr. Jesse, did you have any church announcements or did you want to make a comment?
I wanted to make a comment because can I tell you, I did not know about this until you sent me the information.
Oh,
I
really?
didn't know.
Yes, yes. Well, did you want to add to the conversation before pre-video?
I just thought it was interesting because I'm like, well, because I can see where some, especially the
The
information
confusion
blocking
will lie.
things,
Yeah.
right? And I can see where some people would because I had a friend who wanted to change providers recently, and she was kind of being stonewalled. And I'm like,
Mm.
when as soon as I read that, that's what I went back to, and I'm like, So if that happens again, I know how to
You know
send
how to
somebody to
handle it.
cite a federal guideline. That's
That's
right.
right. That's right. And so while the information is helpful for us in the profession who work with the records and monitor the records and making sure we are in compliance, it's also applicable. The knowledge is also applicable to us as consumers of healthcare services because we have a right to information, our information. We have a right to making sure that we provide the information to other, in your example, to other providers for continuity of care. So, it's my conversation is geared toward the professionals. However, those of us who are consumers can definitely benefit from the information as well because education is key. Once you got that information in education,
Hmm.
what can they do?
That's right.
Can't tell you nothing. I have songs in my heart, so if they just come out, please indulge me for just a few seconds. I'm sorry.
There you go. That's right.
Okay. So today, if you are just joining us, we want to talk about, or take a few minutes to talk about the coder's role in compliance. Now, before you glaze over and roll your eyes, it is truly, our conversation is truly geared toward how the coders and folks in health information can assist. I've recently found this article. Let me see. Let me pull up the article. I recently found this article in the BC Advantage magazine, and I'm trying to see who is it written by. I'm trying to give folks their credit where credit is due. I don't see. Oh, by Sano Patel. I hope I'm saying his or her name correctly. But anyway, about the healthcare compliance and a unique opportunity to impact the business side of medicine. And again, while folks hear the word compliance and they be like, oh my God, here we go. This is applicable, I promise you. So the author talks about how they entered into the world of healthcare, and they entered in through HIM, specifically as a medical coder, just like we talked about last week, huh? And this was kind of their first taste of medicine. Again, the business of medicine and the business of healthcare. They had a whole totally different career way before, but this was some of it carried over. Some of the skills and the things that they needed sort of carried over. So that was good. Oftentimes, people think I'm in a different field altogether and I don't have any applicable skills, but we've always talked about soft skills. Soft skills usually carry over in any industry. So you always have something to bring to the table. You just have to know what to bring to the table and how to convey that. But that's a whole other conversation. Anyway, so we want to talk about how you as a medical coder or in health information can proactively be a part of compliance. And this author feels, and I concur, that compliance is really the backbone of coding integrity. That's actually a quote from the article. But newly certified medical coders are usually guided, bullied, charged with performance metrics and production level standards. And we talked a little bit about that. But they need to think bigger and think larger about coding compliance. So understanding the reimbursement policies, understanding clinical policies, if they're in understanding clinical indicators. Some of it bleeds over into CDI, but some of it is just a well-rounded coding professional so that you understand, again, the why all of this information is necessary and needed. And it helps knowing all of this information for coding these medical claims and understanding how to affect the positive outcomes in your reimbursement in medical practices or hospital systems. All of this knowledge and information beforehand actually assists you as the coder with that additional ammunition to serve the organization that you're working with. So the author also talks about protecting physicians, and she, again, I don't know if it's a he or she, I'm sorry, I'll just say Mr. or Mrs. Patel, the author Patel, that's what I'll say, because I wasn't sure, mentions that the it's about, protecting, she said, he or she said physicians, I'm just going to say providers, because you can advise providers to adhere to the policies and guidelines. Oftentimes they don't really want to hear it, but again, if you're providing them with the service and approaching them as, this is something to help you, this is a resource to help your pocket and the organization's pocket and the bottom lines, oftentimes, that money they'll listen to that money. They'll listen to that, especially if it directly benefits them, and will listen. So it's more of kind of proactive compliance versus what happens on the back end. So even in health information, you are part of the compliance team by providing that information and letting the providers know, hey, this is again the reason why. This is why we tell you, documentation should support medical necessity. This is why we tell you the appropriate. This is why we're providing these queries to you, because there is language, there's policy, there is rules or regulations and guidance that will allow you to document the information that's in the chart appropriately to achieve this DRG or this level of service. And so you're really trying to help. But I believe, and I agree with the author, our health information professionals are at that front line. They're there, boots on the ground, dealing with the providers that can assist in making sure that we're doing what needs to do on the front end. But you also have health information practitioners that are making an impact on the back end as well, because they're doing some audits, they're doing some monitoring, they're doing all of those things to help us make sure our organizations are compliant. The author mentions two of their favorite tools in this endeavor. Of course, the Office of Inspector General, or OIG, their website, where they are listing the monthly work plan, where they list all of the different things that they are looking at or reviewing, and then the reports that come out from those reviews. And so this is something that they use in their work to assist in the compliance efforts at his or her organization, at the author's organization. And then he or she also mentioned, here's another thing that they mentioned. She mentioned the author mentioned the Office of Audit Services, as well as the Office of Evaluation and Inspections. But I want to, so that was kind of to sum up the author's experience as it relates to health information, specifically coders, and how they are part of the compliance team, and how what their coders' role is as it relates to compliance. Yeah, it's all in. So the author also mentions, the adage that we've talked about over and over and over again: documentation is everything. They also mention, but to remain vibrant and vital in the space of healthcare, it's all in the delivery. And they asked the question, isn't it? I also wanted, and I'll let Mr. Jesse jump in, but I also wanted to take this time to actually, and we talked about this before, but to do a kind of deeper dive into another tool that we have at our disposal that I feel is really, really, really impactful for those of you who are working in various healthcare settings, that can help you with the monitoring, compliance monitoring, if you will, or just monitoring in general. If you're watching the money, you're watching the business, but also with quality, utilization, and all of those things. And to me, that's the Pepper Report. And so we'll do a little deep dive in Pepper Report. But Mr. Jesse, do you have any, want to dive in?
Well, I don't think people understand, and even people in healthcare, I don't think people understand the importance of compliance. It is deep. It is broad. It covers everything. Everything. Just like there's a coding policy, there's a compliance policy for everything. It really, really is. And compliance helps. It to me, without it, we would have no clinical integrity, and because we don't have that much now with it. So it's just so I actually, because I'm sure I've told this story before, how I left the job because they were violating policy. And the thing is, and I met with the president of of compliance, and they wanted me to send them guidelines proving what I was saying. I'm like, well, you're in compliance. You should be the one saying this. Not me. So I'm like, I'm not doing your job, because
Here's the thing. Go ahead.
Because then they even asked me how to fix it, because they were having an issue. They asked me how to fix it. That's, well, you didn't hire me to fix it. If you want me to fix it, we can have a whole different conversation. You hired me to be a coder, but because I have an auditing background, I know that what you're doing is not right. But fast forward 3 years later, they got indicted. But go ahead.
Yeah, you always talk about that. I think so. Here's the thing. I think compliance gets a bad name initially, or historically, compliance has had a bad name because people often think of compliance professionals as police. People often, at least it's been my experience, that they hear the word. Well, I've had a mixed bag, because I have that bubbly personality that people be like, oh, she's safe, until I'm not. But until you step out, I draw the box. Till you step over that line in that box, then we got problems. But if you stay and play nicely in the box, have at it. Do what you do, because I feel like I've prepared you well enough. My job is to prepare you with, this is what the rule says. This is what our policy says. Now you can. I'm also the person that believes providing you information on what you can do. This is what you can do, but also couching that. But should you? You know your audience, your policies, your reputation, all of the things. So yeah, you can do XYZ. And oftentimes, these organizations have legal departments, and legal will tell you off the top, oh yeah, let's go. We rah. You can do it. Legally, you can do it. But should you? And that's the caveat to me of compliance. Should you? Really? Let's look at that. The other thing is compliance is everybody's business. So compliance of the organization really doesn't sit square within that compliance department. Everybody has a stake in compliance. Everybody should know the policies and procedures in their own individual departments, in their own individual line of work. Everybody should know. Now, the compliance professionals or the team of compliance folks don't necessarily know what that day ins and out that you know as a person who is on the front line and doing those particular jobs every day. Now, what they will ask you for, I need to see your policy, I need to see your, procedures, and they'll throw that up against any regulations that may be in effect, and then determine what the gaps are, and then how to fix it and how to correct any problems that you may have. But some compliance departments, to me, in my opinion, and in my experience, a great compliance department has people who have multiple hats. They have dibbled and dabbled in all kinds of things. I feel like there should always be someone on a compliance team that is involved with health information, hands down, period. You will be surprised. There are compliance departments that don't have anybody. So in compliance training and education, you get a cursory overview of what codes are and what codes can do. But no deep dive, and so unfortunately, if you don't have a member of the team that is well-versed in health information, then you have to rely on the health information department. And so there should always be a partnering with compliance and health information. To me, those two should run hand in hand. And in my experience, we had, at one of the organizations I worked at, we actually had a compliance committee that met monthly, and there were representatives from, we were a multi-system organization with facilities all over. And so we would have representatives from kind of those high-risk areas, including folks from quality, risk management, nursing, finance, labs, and health information. And I had multiple spots for health information because there are different pieces of health information that is applicable to compliance. We had, folks who were coders. We had folks who were working in release of information. We had all of the things because those are areas that could potentially become high risk. And so we would meet on a regular basis and discuss, we would have those risk assessment conversations. We would discuss, hey, what is happening? What are you seeing? And kind of segue this into that PEPR report. And that PEPR report was a tool that we used specifically with health information to make sure that we were on the pulse of what was happening within our organizations. The PEPR report, PEPR stands for, and it's pepper like salt and pepper. It stands for the Program for Evaluating Payment Patterns Electronic Report. And it's had many owners, if you will, throughout the years, but it really provides you with data on billing rates for medical necessity and coding target areas. It also helps with your compliance monitoring and making sure that you put your resources to good use, because now you have something that that we get data on this, so we can monitor this data on a regular basis. The data that they provide in the PEPR report is specific to your organization. So each hospital has comparative data that is ranked against national organizations or national hospitals, the same types of organizations. They do a comparative analysis, and then you will know whether or not you could potentially be a billing target if you are above the 80th national percentile. So they break them down into percentile. So you have like the 80th, the 50th, and I believe the 20th is how they break those things down. And if you are an outlier, either for overutilization or overpayment, and also underpayment, you don't want to leave money on the table as well. It's just a way to help the organization kind of target and monitor, because sometimes, and it has been in our experience, we would come back and be like, look, we in the 80th percentile in this area, and this area. Somebody need to explain this. What's up? And oftentimes there is a great story behind why we were in the 80th percentile for particular areas. It could be based on the severity of cases that we had that particular quarter, or we've introduced a new business line that now impacts this particular area, which then pushed us into an 80th percentile. But you would never know that unless you had somebody kind of do a deeper dive into those particular cases and say, oh, this is why. And we're okay. And again, I was about to give a whole other example, but like with my providers for E&M, if they are providing or coding services at higher levels, it's okay to code service at higher levels. You just got to make sure that you, one, actually provided those services, and two, document it, and you're good. So let your documentation speak for you. And again, this was one of those instances with using the PEPR that it allows you to document or have the documentation support why you may have been a particular outlier for one of the rankings. Okay, I'll stop now, Mr. Jesse, if you wanted to jump in.
No, I totally agree. And I think that this is we're having a very technical conversation, but it has very practical and very real world implications. And I think that, a lot of people don't really realize all of the inner workings of compliance and the behind the scenes that really affects the bottom line a whole lot.
Mm-hmm. So even on and I'll make sure the link to the PEPR, here, maybe I'll show this to the website. Okay, let's see. I know, but I don't have two monitors today. So we gonna have to do what we gotta do. It's giving me grief. Okay. So I think I'm sharing. Yeah, I'm sharing. Okay. So
yeah, I can see it.
Okay. So here's the information about the PEPR. And it gives like who can benefit. And so they talk about, your senior leaders, your chief financial officers, compliance officers, but then they also have a whole line item for health information management staff. And so they can use the PEPR to identify potential DRG, overcoding and undercoding, identify DRGs that are problematic on which the hospital or facility may want to focus, auditing and monitoring, access tables and graphs displaying billing activity over time in comparison with other hospitals or facilities, which can be used for educational training activities, prioritize areas for coding compliance, auditing and monitoring, and aid efforts to improve medical record documentation. So it provides all of the wonderful things there that you can use quarterly to help you in those endeavors. Now, again, it has been my experience that your quality departments actually usually get first dibs on the PEPR reports. And so again, you need to have a relationship with the quality people so that they can share those reports. And what we actually would have, I would have like a little tickler in my calendar for me to reach out to the quality. I had some who will be on it, like boom, because again, these reports come directly to your facility. So all of my quality directors within all of my facilities would send me their PEPR, and then I would take and aggregate the information for our organization based on what we had. And so you have resources for short-term acute care hospitals. You have critical access hospital data, home health agencies, hospice, inpatient psychiatric facilities, inpatient rehab facilities, long-term acute care hospitals, partial hospitalization programs, and skilled nursing facilities. And so they're also focusing on some outpatient monitoring and data as well. So again, you have all of this stuff. And this website is actually very valuable. There's some training, there's some YouTube videos that were created. I think this organization created to provide you with step-by-step training on how to actually look at the PEPR and what type of data you should glean from the PEPR. I did want to show, okay, let me see how we're going to do this again. I did want to show kind of some data information. Let me see. A window. Yeah, okay. Yeah. Okay, so this is from, I'll wait till it comes up. This is from fourth quarter 2022. And so remember, all of your PEPR reports come out quarterly. And so you have like a target area. And so this will list all of the various target areas that the PEPR would have taken a look at based on the DRGs, based on all DRGs in those particular areas. And it looks at the total number of discharge. So you have the total number, and then it gives you comparative over, this would be a full year for 2022 because you have first, second, third, and fourth quarter. The average length of stay for this target area, the average Medicare payment for this target area, and then the sum of Medicare payments for this target. And so you see those huge numbers there. And this, they provide this information for all. So again, when you take and look at, what target areas you may be out of an outlier in, this again can provide some additional information on the story that you're telling when you have to put together your report to say, okay, well, now this is why it's important. This is why this may be a potential risk for us. Maybe we need to take and put some resources in monitoring this for a little while, especially if you see some over a year or a couple of years where, hey, we're consistently in this 80th percentile. And if you have a great story to tell that justifies, then you can move on and say, look, we already know, we already looked at that, we good. But if not, then this may be something to watch. And then, if you see where, hey, these are some target areas, and maybe we haven't made the 80th percentile, but maybe this is some things that we may want to take a peek at, or if you in your CDI departments or programs, we have a problem with septicemia, and let's find some additional support to get an understanding of what's happening around septicemia. So when we prepare our education, we have some clearly documented data and evidence on, why we feel it's important that we are taking the time to, and based on the information that you get and glean from your work in CDI, where you've hopefully began to monitor. This is what we see on a regular basis. Oh, another thing, this data drills, while it goes to your facility, this data can drill all the way down to a provider. And so say you have a provider that you already know that has some issues in certain areas, you can go back and double down. Not only do we see this, but the government sees this, our payer sees this. So let's make sure that we are all on the same page and providing the additional information. So I just wanted to kind of show you some of, and then talk about the medical DRGs with CCs or MCCs and the data related to that, surgical DRGs, all of the things. So yeah, I just wanted to kind of share information. Information that you all could use. Good morning, healthcare business consultant, that you could use to help you in your to strengthen you. Again, I'm always about helping you be a marketable certified medical coder, and this is some additional skills that or tools that you can put in your toolbox to help you walk in that thing knowing about the why behind the machine. There was something else I wanted to say. There was something else. Oh, I also found some additional target areas. So they kind of review and monitor. You have some tried and true trusty target areas that you'll see from year to year, probably from the inception. But then you also have some target areas that they move around. And the report on Medicare compliance reported back in April some changes to some target areas, and the spinal fusion target area on the PEPR now includes some outpatient claims as well as inpatient claims. And so again, there's a shift from care going from inpatient to outpatient, and especially when things were popping, well, as things pop off of the inpatient only list, they want to continue to monitor some of those services. So they're including both of them. They also mentioned they removed some target areas. So the emergency department evaluation and management services and admissions for chronic obstructive pulmonary disease and excisional debridement were popped off. They are no longer part of, or they weren't on the latest quarterly release for short-term acute care hospitals as target areas. But again, you know, they comparison analysis to determine, you know, what looks good. This is something that we're seeing. This is something that we're hearing. You know, they take all of those things into account to determine what those specific target areas are. And yeah, that's all I wanted to kind of add to that. So you do see it's all over the place, and, you know, folks are watching this. And again, this PEPR report is another tool that you as a health information professional can use to assist in making sure your organization remains compliant in all of your revenue cycle endeavors. That was a good way to sum that up.
Definitely. It really is important. And there's so much data out there that I think a lot of people they don't realize that there's a lot of resources to help them. Mm-hmm. Like you don't have to take stabs in the dark.
You don't. You have, and when you're looking for the black and white documented information, you know, these are some of those places that you need to go to. Like the author said of the original article that we discussed, you know, OIG, you hit that work plan, and usually when at least in my experience, compliance professionals gather and we're looking at, you know, some of those risk areas, you know, we're that risk, that work plan is top of mind. Hey, you know, years ago, they used to give you the annual work plan. So it made it a little easier where you could kind of trend and look, okay, for the year, this is what we're seeing, whatever. Well, now it's given to you on a monthly basis. So you have to do that annual kind of compilation so you can determine what may be a high risk area for your organization. But it gives you all the background information. And so you can say, hey, this is a hot topic here. Let's take a look and see how this impacts our organization. We provide these types of services. Are we at risk? And what are we at risk for? Are we at risk for overpayments? Are we at risk for underpayments? Are we at risk for medical necessity issues? There's a whole bunch of things that you could potentially be at risk for. And once you take a look at your organization, then you can level set that risk. Is it high risk for us, low risk? Should we not even go there? But again, you've taken the opportunity to assess what is happening within your organization and provide your leadership with information so they are not blindsided. Some of these things that we get or the organizations receive related to documentation requests and all of those things, that stuff comes from, they're doing the same thing that we're doing. They're just doing it on a broader level. Like, well, let's go and see what all these facilities are doing. So let's ask for the documentation because, it impacts their work as well. You have your payers, they're paying attention to the work plan as well. Like, they looking at this. Well, let us look at this and let us look at abroad. And so let's get some data. And so that data is asking for those organizations that are contracted with that particular payer for their documentation. So they're providing the information as well. She said, oh my God, I'm about to holler. They need pepper, cayenne, and sriracha.
That's a good one.
For provider offices, because their professional outpatient side is atrocious, but nobody asked LaShanta. Oh my God. Leave it to her to bring us some humor on the topic, but she's absolutely correct. So again, this, while it has those focus areas in, because it was originally born and made in the hospital setting, you can take and glean some of this information for the outpatient setting as well. And they do have some additional resources for that. So, and like I said, it drills down all the way to the provider. So if you have a provider that is problematic or provides you some some pause that makes you want to clutch your pearls, you can always go in and have again, once you get the information from your quality people, you can drill down and look and see, is there a pattern here with this particular provider, and hopefully have that provider allow you a few moments of their time for a discussion. Cool. So that's how I believe, health information professionals have a role in compliance and can assist in this part of the business of healthcare for their organizations and for all, and give you a bankable skill, because again, this is all part of data analysis. You may not be on that front end taking all of the ICD-10 codes or CPT codes and doing the counting and all of that, but this is still a large component of data analysis, because you're taking the information and you're comparing it. And while they give you some of the information, you then go a step further and determine and decide, okay, well, let's take a look at 10 charts in this particular target area and see what happens. And then you come up with the data specific to your organization, more real-time current data. So yeah, I do too. I am a compliance advocate, as you all know. Yay! So I love compliance. I'm studying for my certified professional. Okay, Is that compliance? You cut off there, but yeah, compliance officer. Okay. Oh, okay. So yeah, that's with the AC, I believe, the CPCO. Yes, yes. And so there are, I think AHIMA has something related to compliance, loosely. And then you also have the Healthcare Compliance Association, and I am certified through them. Yeah. So yeah, there and so again, I believe that a good compliance team should have health information professionals on it, because oftentimes they don't even know where to begin. We'll see something and we'll be like, okay, what's the codes? So we can start gathering some data. You know, you can then go in and all your data analytic people, you know, your team, y'all can start pulling some stuff, or you can, you know, ask, can you generate a report on XYZ if you don't have the wherewithal to go in and do it yourself. But you got to start with something, and oftentimes it's the codes that'll provide you the data. And if you don't have any clue about the coding that's associated with it, you in the dark, you at a loss. You better call your health information professionals, call that department and ask for some help. Be friends, take somebody out to lunch, coffee, tea, something.
That's right. Because, you know, I think that all of these, what a lot of people don't realize, and what I see almost daily, is people want to, people in other areas of HIM, they want to dismiss coding, but what most people don't realize is almost everything in healthcare comes down to coding.
It does. In
And
documentation,
I don't
documentation and your coding. You are absolutely correct.
Yes. And why I just don't, well, I have my theory as to why, but we ain't going to, we had a nice session. We're not even going to go there. But it's just this is how you can become marketable. Like, you know, Clarice always talks about, because when you are a coder and you know just a teensy bit about compliance, believe me when I tell you, that's more than what most people will know that you work with. They don't
That's
think that any of this correlates. They just think it's just like, oh, off in the wild blue yonder, and it's not. It is all tied together, and you know, just like it's just so important. And I think that it's a great skill set to have in addition to coding.
Yep. I say that all the time. It's either documentation or coding that goes right or wrong. You're absolutely correct. And this, you know, helps you walk into several doors and sit at several tables knowing your worth, because you got it. You know it. And so they're looking like, well, wait a minute, hold up. You said what? Who? What? You know, you start throwing that stuff, and it's like, oh, it's a whole different world now. It's a whole different world. So again, today we just wanted to give you some things to think about, to ponder on, help you understand your role as it relates to compliance within your organization. Because again, as a health information professional, you do have a role in compliance and helping your organization, as well as, and this is kind of an offshoot, but the integrity of the coding and the integrity of the documentation. All of those things work hand in hand. And so there are downstream effects and impacts when those things are not correct or accurate. So yeah.
Absolutely.
That's a different level of gatekeeping. It's a positive gatekeeping, if you will.
Yeah. That's the kind of gatekeeping that should be happening.
Yes, that's right. Those are the gatekeeping. Uh-oh, the crafty coder is on one today. Like, right, I don't F off at the round table, flipping my locks and dropping the mic on my way out. I said what I said. Exactly. And when you have the information and the regulatory support and documentation, you said what you said. Again, and like I've said a gazillion times, I don't even take it personal. I've learned in my years of experience in compliance, you can't take the stuff personal, because one way or even to Mr. Jesse's testimonial, one way or the other, it's gonna get them one way or the other. You can either try to save them on the front end by providing them with the information and kind of outline, hey, this ultimately could be the worst case scenario or a bad outcome. Or if we fix and change and correct and pivot, then this could be a more positive outcome. But my job is just to provide the information and provide the recommendation. Everybody else's job is at a higher pay level than mine to determine what it is that they want to do within their organization. That's always been my thing. And I can't take it personal. Now, in my business, of course I'm gonna take it personal, but for somebody else's, no, I did my job. I did my part. I gave you what it was that you needed to assist you in favorable outcomes and favorable options. And hey, you can choose. You can get with this, or you can get with that.
Thank you. I was thinking the same thing. Oh,
I told you there's songs in my spirit today.
yeah, I was thinking the exact same song. Because this is where it's at. Okay.
This is where it's at. This is where it's at. Oh, that was fun. All right. Let's see what we got going on. She said, right, argue with the guidelines people, AMA and CMS. That's right. I don't make the guidelines. I don't make the regulations. I just report on them. I just give the, I like that. This or that. I just provide the information.
I used to say it all the time when I was in an auditor at a company. I'm like, I don't make the guidelines. I just get paid to follow them. Mm-hmm. That's all.
As we all do. As we all do. So especially for somebody who is new to our profession or considering coming to our profession, know that it's bigger than just taking, and I love how the author put it, where you are initially inundated with productivity metrics and this, that, and the third, and all of those things. It's bigger than that. And so hopefully someone is also, and if they're not, you can always come to us, because here on a Saturday morning tea, we give you the tea. But there's also additional information and reasons why behind what it is that you're actually doing. So yeah, hopefully come with that knowledge. Let's see what.
And a lot of people don't.
And the AMA will let them get on board to express their opinions if they just take time. I understand their concerns, but I can't change it. I agree. Go ahead, Mr. Jesse. I'm sorry.
And a lot of people don't. It's just interesting how it all ties together and how people just really miss it's almost like basic stuff. But I do understand, because like there's nobody who ever really gives any pushback. Oftentimes, like they just let it slide. Well, this is what they said. And it's like you also have to have people, you have to have the right people in the right positions, because anything can become a runaway train. Anything. If there's no compliance, if there's no checks and balances. So, and this is really why healthcare has kind of like run off the rails, because in so many institutions, there's no checks and balances.
Yes.
And
they're so interested in moving forward or getting the next service level or chasing the dollar or whatever, and not really assessing. They don't take the time to really assess I'm a pros and cons girl. I've been that way since probably a teenager. Like when I want to think about something or make a decision, I get just a piece of paper and pro and con, and I list it all out, and I still use that same type of formula today with decisions and recommendations that I provide to folks. Here are the pros, here are the cons, and choose to move accordingly.
And what a lot of institutions have to realize, especially providers, is it's okay. And well, all institutions on every level, especially HIM and coding, because there's this whole concept where you and coding and CDI has to agree on a DRG before the case gets sent out, before it gets final billed and all that. I understand that. But what people have to understand at these organizations is that when it hits the insurance company, that claim will go through 2 reviews. It will go through coding validation and clinical validation. It starts with coding validation first, then it goes to clinical validation. And at either point, that claim can be denied. And once it gets to, and it's easier to rectify a coding validation denial rather than a clinical validation, because clinical validation 9 times out of 10 is definitely going to be documentation or medical necessity.
Yep, you are absolutely correct. And folks don't, they be like, oh, I done did my X number of charts that I need to do, and I'm out, I'm done. No, that stuff gonna trail and follow for a minute. It's gonna trail and follow. Yep, she said, oh wait, there's more. Microwave world want everything now, would rather be booked and 1,000 denials rather than to take time to document properly and dig their toes in the sand on vacation with no denials. Shenanigans. And then she also says, right, every claim should be correctly coded first. You're absolutely, that should always be the goal. Always. Always, always. All right. Well, I think this was good. I think this was informative information you need to know. We even got some chuckles out of it.
Yes. Look, courtesy of A Tribe Called Quest.
Oh my goodness. No, I think that's, who sang that? That wasn't A Tribe. That
wasn't it? It wasn't them. Wait a minute. It was somebody from some group from New York.
It was a group from New York. Oh God. I'm seeing the video and everything in my head. Oh, it was an 80s group. I don't think it was Tribe Called Quest though.
Okay.
You gonna make me look it up? See, sir.
It was Black Sheep.
Okay. Like yes, okay. But yeah, that was all good. See, we gotta make sure. See, you see how we do our research. When we don't know, we gonna go look and search and find and figure it out. And hey,
it's no reason to walk around here not knowing.
No, we're not gonna. We're not gonna know. We're gonna not walk around knowing. We're gonna get down to the bottom of it and figure out what it is so that we can share it. Yes, that's what we do. I love it. That's how we became family in the beginning. Well, thank you all again for joining the Saturday morning tea. Was the tea spilled today? Was it spilled today?
Each and every Saturday.
So if this information was valuable for you, help us share this message by liking the video, sharing the video, and subscribing to the channel, the Professional Reimbursement Network. You can also check out the Coding Nurse channel on YouTube. Yes, there are some gems over there. Check out the Coding Nurse and see what Mr. Jesse has to offer. Make sure that you like the videos. Thank you all for joining in our conversation today. It's been fabulous. And see, there's no pressure. There's no, You can build that keyboard courage right here.
That's
on
right.
the Saturday morning tea. Oh my God. You can build it right here. Start with us. And then you go, you build that confidence and that assuredness, and you can take it offline, and you can take it to the room, the boardrooms and the tables that you sit at. So this is still I'm always
That's
about
right.
training. This is a practice ground
That's
here
right.
for having those conversations. Oh,
And as we
goodness.
always advocate, before you do that, do your research.
Oh, don't go in there half cocked and not know what you're talking about. That's not a good look. Now that is not a good look. I know I would go in and they'll be talking about something and I'll be like, I don't even know what they're talking about. I ain't got nothing to say. They'll be like, well, Clarice, you don't have nope, not at this time. Let me write this down because then I can go back and research. But I'm not going to give any information on. I remember there was a colleague that worked in the legal department at one of the organizations I work with, and we used to be on several because she was the chief legal officer for that particular region. We would be in several rooms together, and she would always, she want to pull me aside and would say, you didn't add, or you didn't say XYZ, or you did. And I was like, because ma'am, I have no information about that. Now, until I get some information, that's when I'm going to speak. Because never, ever, ever will you come back and be like, Clarice told us so and so and so, and this was incorrect.
That's
Absolutely
right.
not. I'm very comfortable in I'm sorry, I don't know, but I'll find out for you. I'm very comfortable there because there's so much at stake. My reputation at that point is at stake. Ain't nobody playing with that.
That's
No,
right.
sir, no, ma'am. No. And so you have to, get comfortable, sit in that thing that you bring to the table, and know your strengths and weaknesses. And I do. All right. So this was fun. Make sure when you subscribe to the channel, you also hit that notification bell if you're on YouTube, and it'll let you know when we come on and join when we have our Saturday morning tea every Saturday at 9 a.m. Eastern Standard Time, even though I'm on Central Time and I'm confused, but it's all good. Be like, I don't even know what time it is for real. I have my computer says one time, my phone says another time. So as long as I show up when I'm supposed to show up, it's all good.
There you go.
So again, this has been a great session. Mr. Jesse, do you have any closing parting words before we head out to the meeting behind the meeting, or the meeting after the meeting?
As always, I just thank you for creating a space where we can have some real conversation and really add value to people who are either in or thinking about transitioning into HIM, because it's an amazing industry and there's room for everybody. And you just need to come up with a plan and do your research and get some knowledge and stand in that knowledge.
Yes. Well, I love it. So again, thank you all for joining. Remember, be safe, be kind, and don't wish for it, work for it. Until next time, take care. Have a great weekend.
All right. Bye-bye, everybody.
Bye.